Welcome to your lecture regarding Chapter 33, Adrenal Drugs. Still working on drugs which affect the endocrine system. And like I said, we're going to be working on adrenal drugs today, which is Chapter 33 in your textbook. A few objectives will just quickly step on the anatomy and physiology of what the adrenal glands do. Now, if you can understand what the adrenal glands do and what their function is within the body, understanding the side effects and indications for these medications is going to be a lot easier. So I do encourage you, if you're a little fuzzy on what the different hormones do and what the adrenal glands do, to review it in your physiology notes if you've taken physiology. Otherwise, just make sure you kind of familiarize yourself with it. We'll do just a 10-second real quick review over what they accomplish within the body, but I'm not going to take a lot of time preaching stuff that you've already been taught. We're also going to compare the hormones secreted by the adrenal medulla versus the adrenal cortex, compare and contrast Cushing's syndrome and Addison's disease. One is a disease of hypersecretion and the other one is hyposecretion. And then we're going to talk about two specific corticosteroids, the glucocorticoids and the mineralocorticoids, and what they do in the body and how they can be used for pharmacology. Along with that, we'll talk about a couple different types of medications, talking about mechanism of action, indications, routes, cautions, all that fun stuff. And then last but not least, develop a nursing care plan that includes all phases of the nursing process for patients. And I have a little bit of an example of that at the end of your notes. This will be a rather fun lecture in the fact that there's lots you can do as far as preventing side effects, and you can have a lot of hands-on education, prevention, monitoring. It's kind of a challenging group of drugs to work with. So in that aspect, I think you're going to enjoy kind of stretching your knowledge a little bit and developing those skills. So again, just starting at the beginning with what the adrenal glands do. As far as where they're in the body, they're located right here on top of the kidneys. They sit here, you get two of them, a right and a left, top of each kidney. And they're divided within each gland to this inner and this outer. So the outer portion is called the adrenal cortex, and then the inner is the adrenal medulla. The adrenal cortex is about 80 to 90% of the of the gland, And this picture doesn't do it real good justice. I think they were trying to emphasize the difference between the cortex and the medulla, but the cortex is substantially bigger than the medulla. This is pure endocrine tissue, so it's only secreting hormones. It doesn't secrete any neuro type of stuff. That belongs to the adrenal medulla. The hormones which it secretes are the corticosteroids, which we call steroids. These type of steroids that we're talking about right now are not the steroids which are used in abuse in athletics. Those are anabolic steroids, and they're different. These would be, when I say a steroid in this lecture, I'm just referring to the corticosteroids for clarification. The three which are secreted by the adrenal cortex are the glucocorticoids, and they're secreted by the middle layer of the cortex. This is going to be the specific hormone which has anti-inflammatory indications, and that's typically the reason why we administer these drugs to patients, is they have some sort of inflammatory disease or disease process or clinical manifestation that we need to suppress. So you'll see that's the reason why they're typically used. Other properties of the glucocorticoids include a carbohydrate and protein metabolism alteration. Now, this is where a lot of our side effects of corticosteroids come into play. When we reach that portion of the notes, you're going to note that there's a lot of side effects, and this is one group that we really can't say, here are your three big ones. Unfortunately, that whole long list is likely to happen. And this is also where the challenging part comes in, trying to minimize the incidence of the side effects and prevent them when at all possible. But in regards to the altered metabolism, this is where a lot of the weight gain comes from, and then it also causes patients to have an increase in blood sugar, which can induce a diabetic state, even if the patient's not diabetic. Because it's altering the metabolism of carbohydrates, it's also going to be this group of medications can be used cautiously in diabetic patients because they already have goofy carbohydrate metabolism anyway. Glucocorticoids are also used for the maintenance of normal blood pressure, so you're going to see monitoring blood pressure becomes a really big deal in patients taking these medications because oftentimes the blood pressure will increase while you're on these. And then this is also where your stress response kind of originates from. There's a specific corticosteroid called cortisol, and that's been deemed your stress hormone. So whenever you perceive stress, whether it's physical or emotional or psychological stress, your body naturally secretes more of the glucocorticoid cortisol, which then increases your blood sugar, increases your blood pressure, increases everything. It's really bad for your body and also causes you to gain weight. And this is one reason why people who are under a lot of stress sometimes gain weight easier than those who are more laid back. The other corticosteroid that we're going to talk about are the mineralocorticoids, and these are going to be secreted by the outer layer of the gland. Now, this, as the name indicates, is going to regulate the mineral salts, particularly sodium and potassium. It also secretes a hormone called aldosterone, and aldosterone we'll talk about again when we talk about blood pressure medications, because aldosterone has two main functions in the body. One, it controls how much sodium is retained, and then it's also a potent vasoconstrictor, which is going to increase blood pressure. So with aldosterone, when it gets secreted, it causes the body to retain sodium, and water will follow sodium. You might remember from physiology. So as you retain sodium, you're retaining water, and then that increase in blood volume, because if it's not getting excreted, it stays within the bloodstream. That increase is going to result in hypertension. So this is another reason why patients who are on these medications typically have a spike in their blood pressure. We want to make sure it's not getting too high because that can cause issues as well. Also from physiology, you might remember that potassium and sodium typically work opposite of each other. So if you're retaining sodium, you're probably excreting potassium. And one of the side effects of mineralocorticoids is hypokalemia, or a low potassium. We worry if the potassium gets too low in the body because that can result in cardiac dysfunctions. Also, aldosterone causes hydrogen ions to be excreted, which can then alter the pH of the body as well. And your body's pH really doesn't like to be altered, so any sort of touching on that can cause problems. The third one, which we're not going to talk a whole lot about now, is the androgens. And androgens is a sex hormone, and it's more specific to the male body than is the female body. And that's secreted by the very inner layer of the adrenal cortex. And then you have the adrenal medulla, which is the inner portion of this gland. And this part has both neurosecretory tissue and endocrine tissue. So you'll see epinephrine, norepinephrine is sometimes created from here and released into the bloodstream. And then it also, norepinephrine, epinephrine is both a neurotransmitter and a neurohormone, so it's kind of a both. We're not going to talk a whole lot about the medulla today because most of our medications are not altering that part. The drugs we're going to talk about within this course are going to work on the cortex. So how this system is set up to work is it follows the HPA axis, which is your hypothalamic pituitary adrenal axis. Your hypothalamus, if you want to think of that as being the dictator or the president of the endocrine system, that's a good way to think about it. The hypothalamus gets information and then it starts sending orders to the pituitary gland, who then starts to execute those orders via various hormones. So the stimulus to secrete from the adrenal glands comes from a signal which is going to originate within the body and go to the hypothalamus. The adrenal glands don't secrete on a 24-hour basis. They only secrete their corticosteroids when there's a need within the body. So if levels are good, the adrenal glands take a break and they just hang out. Then when your corticosteroid levels drop low, a signal gets sent to the hypothalamus. Hypothalamus sends a signal to the pituitary gland. The pituitary gland secretes a hormone, and that hormone goes to the adrenal glands and wakes them up and takes them off vacation. They do their thing for a while, and then once the levels are high enough, a negative feedback goes to the hypothalamus saying, oh, we've got enough or we have too much, and the whole process starts over, except for this time, instead of stimulating the glands to secrete, the message is going to be stop secreting. So just kind of following your outline there, there's a sensor which sends a message to the hypothalamus, your president of the system. The hypothalamus then sends a request to the pituitary gland to secrete a certain hormone. And the hormone which gets secreted is going to depend on which corticosteroid is low. Whichever hormone then is secreted by the pituitary gland is going to circulate down to the adrenal glands, and it's going to stimulate the adrenal glands to start secreting their corticosteroids. Typically, it's a low blood pressure that causes this to start going. When there's a low blood pressure, the body wants aldosterone, so that sends this message through to get the adrenal glands to secreting aldosterone to bring the blood pressure back up. But this is kind of a slow mechanism. This certainly is not as quick as the sympathetic nervous system bringing up the blood pressure, but it tends to work more for long-term use. And your book has a nice example, again, on aldosterone and how it works, and that's also on the screen. You've probably read by now. So when the body's not balanced, because sometimes something breaks, and it's typically the HPA axis breaks, and then you'll either get a hypersecretion or a hyposecretion. For hyposecretion, we technically call that Addison's disease, and it's caused by some sort of break. So either the hypothalamus is sending inappropriate signals, or it's not being sensitive to the signals which is sent to it. Now, what that looks like clinically is the lab work goes all out of whack. So sodium gets excreted instead of retained. So you're going to have a sodium level of less than 135. 135 is kind of the low end of the normal sodium. If you didn't know that, normal sodium spans from 145 to 135. So low sodium is less than 135. And then that can clinically look like confusion in your patient. These patients get kind of confused. It can lead to seizures if it's not corrected, so there are some pretty serious consequences if the sodium drops too low. Digressing though, these patients also tend to be hypoglycemic, which we talked about in the previous lecture, blood sugar of less than 70. Again, they get confused, lethargic, might complain of intense hunger, that kind of stuff. And then if you're losing sodium, you're probably retaining potassium now, so hyperkalemia would be your next clinical manifestation. And that's technically a potassium level of greater than 5. Potassium, kind of connect that to the heart. If it gets too high or too low, it causes cardiac dysrhythmias. And both extremes can be fatal to the patient. So it's one that we really want it to stay right within its range and not veer one way or the other. Also, as you're losing sodium, water follows sodium, so these patients tend to be dehydrated and they lose a lot of weight. To treat this, we just supplement with a corticosteroid. Now on the flip side of the screen, you're going to see Cushing's syndrome, and that's going to be a hypersecretion, again, typically caused by either a malfunction of the HPA or a tumor which is causing oversecretion. So the hypothalamus might be sending a signal to stop production. That's working appropriately, but if there's a tumor within the adrenal gland or within the pituitary gland, that can sometimes just, the tumor ignores the sensor to stop, it just keeps producing and goes crazy. Now clinically, this is going to look the exact opposite of Addison's disease, because your hormones always kind of follow. Your hyper looks exactly opposite of your hypo, so it's kind of easy. And I know this really annoyed me when I was in nursing school, and my instructor told me, all you have to know is you either need to know hyper or hypo, and not worry about the other one because you can figure it out, and that always annoyed me in class. But I'm going to tell you the same thing. If you can memorize what Addison's disease is, jot that down on your test, and then just know Cushing's syndrome is the exact opposite of what Addison's would look like. But stepping through it, clinically, sodium gets retained, so you end up with hypernatremia. Glucose gets retained, so you end up with hyperglycemia. And then as you hang on to water, or sodium, you're going to hang on to water, so you end up with a overhydration or a fluid volume excess. And with that extra water, you can end up with a spike in blood pressure. So a lot of times Cushing's syndrome, they have a really high blood pressure and a rather low pulse. And then there's a redistribution of body fat. And instead of weight loss, they end up gaining weight. So it's just the exact opposite there. So adrenal drugs, and you certainly don't need to write this whole thing down, but I'm just kind of throwing it out. These can be classified in a couple different ways. If you're trying to vigorously write this down while I talk, the only thing you really should worry about is the duration of action. In clinical practice, that's typically how they're categorized, if they're categorized at all. But there's other classifications. They can be called natural or synthetic. Natural is just a naturally occurring thing. Synthetic's derived from a lab. Most of our medications are now derived from a lab. They're no longer the naturally occurring stuff. Can also be classified via method of administration, systemic, topical, or inhaled or intranasal. Now your systemic is going to be via an IV or IM. So if you're giving it IV or IM, it's going to have the most potent side effects and the highest incidence of side effects. Your topical is going to have the fewest side effects, and your inhaled and intranasal corticosteroids are also going to have very few side effects associated with them. Systemic, you might use a systemic one. It can also be called oral too. I don't have the pill, the tablet form up here, but there's certainly tablet ones as well. The systemic and the tablet type of corticosteroids are going to be used for like immunosuppression, so such as diseases of lupus, trying to prevent an organ rejection, something along that line. Topical is going to be like, if you look at the drugstore, you'll see a medication called hydrocortisone, or what's other? I forget the other name for it, but it's just a topical cream to treat like a rash. Like if you get a bug bite, it's an anti-itch thing. And then inhaled are used in the treatment of asthma and COPD, and intranasal can be used for allergies. So you see how this has a wide span of what we can use to treat, or of everything these drugs can treat. So that makes them pretty significant to practice. Also, it can be based upon the duration of action. Short obviously has the shortest duration of action, with intermediate and then long. Most of the ones we give are going to be an intermediate, so we can give them every other day to help decrease side effects. Or they might call them both. It might be an oral intermediate acting medication, or a short inhaled, or something along those lines. So that's just your FYI, so you kind of understand that. Talking about the mechanism of action, they all work by modifying enzymatic activity somehow. Some of them work on aldosterone, and some of them work on the glucocorticoid drugs. Your aldosterone is going to be more of your mineral corticoid hormone, so that's going to be focused on promoting sodium reabsorption, and with sodium follows water. So that's going to result in an increased blood volume, which is going to increase the blood pressure. And then with that extra blood volume, a lot of times the vessels will get so full that they become a little bit permeable. And when your vessels fill up and they're to their maximum capacity, then fluid will start seeping outside the vessel. And when it sits in that interstitial fluid or interstitial space, that's when it becomes edema. So that's what aldosterone, when it's secreted, does. Sometimes we want this to happen, such as the case if somebody has low blood pressure, we might wish for this to happen. In addition, or as the sodium is reabsorbed, the excess potassium and hydrogen will also be excreted, which is going to result in hypokalemia and then also metabolic acidosis. Hypokalemia is going to be a potassium of less than 3.5, and then metabolic acidosis is going to be a low pH. The other hormone that we talked about are the glucocorticoids. Now this is where typically where the indication for using these medications come from. Most of your drugs which have glucocorticoid action will also have mineralocorticoid action too. So you'll see that we're giving this to help suppress inflammation, but it's still going to cause all the other things that the mineralocorticoids cause, because there tends to be some crossover there. Not a lot, but some. So anyway, we also have the glucocorticoid drugs, and this is going to be like your hydrocortisone cream or your cortisol as well, are two examples of those hormones. Again, it has moderate mineralocorticoid activity and aldosterone activity. For that reason, there is going to be some fluid retention, so partial spike in blood pressure, and then it has that potential to cause hypokalemia. Now, what we typically take these for is the inhibition of the inflammatory and immune function. So it works in 4 different ways to help support this. First off, it stabilizes cell membranes of inflammatory cells. And then what's going to make more sense to you is it decreases the permeability of the capillaries. So when the inflammatory process is stimulated, you sprain your ankle and your immune system is going to the rescue to cause inflammation. Inflammation is the first step of healing, so it's an immune-driven response. Anyway, the immune system comes in when the first thing it does is it blows up your blood vessels to make them really leaky. As they get leaky, it allows the immune system, the white blood cells, to go within the blood vessels to outside the blood vessels, and then it's going to start cleaning the area up. So it wants them to be leaky. Now, if we suppress that permeability, you're going to stop that edema. This only works to a slight amount, though, because one of your side effects is fluid retention. So sometimes these two kind of cancel each other out. Stepping down to the next one, though, this is the next big thing that corticosteroids do, is they decrease the migration of white blood cells, which means it's shunting the immune system away from wherever it's working. So essentially it goes there and just kind of pushes all the white blood cells away from the point of where they're trying to work. So like in the instance of autoimmune diseases, that's a disease where the immune system is inappropriately attacking the own body. So instead of sending in a person with an autoimmune disorder, like say rheumatoid arthritis, it's a disease where the joints are getting attacked by the immune system. In those patients, when they take a corticosteroid, the corticosteroid goes to the joints which are inflamed, and it kind of shuts that immune system off. So it shunts them away. It stops that inappropriate attack. One of the reasons why we use these drugs, or a big reason why we use these drugs. One of the side effects, though, is that it increases your risk for infection. So again, it's a double-edged sword, but sometimes necessary. And then last but not least, it also reduces fever. Where a lot of our side effects come from will be point number 3 on your outline, and this is going to be under the metabolism. Glucocorticoids or corticosteroids promote the breakdown of protein, so this means they're also going to cause muscle wasting and muscle loss. It's not unusual when you go on a corticosteroid or when a patient goes on a corticosteroid for them to lose their lean muscle and gain fat, and that's really a hard thing for patients to agree to, taking this drug that they know is going to decrease the amount of lean muscle they have, plus it's going to make them retain fat or get fat, increases their fat content. So that's not much fun, but it's what they do. Number B, or letter B there, is promote the breakdown of glycogen in the liver. This is where your increase in blood sugar comes from and why these medications need to be used with extreme caution in diabetic patients. It's not that they won't ever be used, it's just if they're used and the patient's diabetic, they may need insulin, and they may need a higher dose of insulin than what they take at home. It's not unusual, I work on a surgical unit, so it's not unusual for our patients who are diabetics after surgery. We see the surgery itself evokes a stress response on the body, so cortisol, your corticosteroid, is secreted naturally. As it's secreted, it causes blood sugars to spike up. So then clinically, I'll check a blood sugar and it'll be in the 200s, and the patients are just shocked because it's always in the 120 range. Why would it be so high? And this is the reason why it's high. It'll go away. It's nothing permanent in that instance, but you just need to be mindful so that you can treat that while it's high, because otherwise it could cause problems. Induces lipolysis and fat redistribution. And then D is stimulating bone demineralization. And this is going to be more of a long-term thing. So if somebody's on a corticosteroid for a long duration, long time, say they do have RA, rheumatoid arthritis, that's a disease that's not cured, it's just controlled. So those patients might be on these drugs for years even. In those patients, over time, these drugs will cause their bones to become more brittle. So then we become worried about osteoporosis. So one of the interventions for somebody, say they have rheumatoid arthritis and they're starting their corticosteroid, you may also suggest they start on a calcium supplement, or you might suggest weight-bearing exercise to help build up the bones and prevent that demineralization. Well, it seems like that's something the physicians should address. A lot of times it falls to nursing to implement these plans. So just be kind of thinking around and in addition to taking this medication, this is how you can also help prevent some of the side effects. Because like once osteoporosis occurs, it's really hard to reverse, and then those patients are at increased risk for bone fractures, which isn't very helpful to them. Now, indications. I already said these drugs can be used for a vast variety of different disorders. We have them kind of grouped here into endocrine, autoimmune, and inflammatory disorders. Truly, the autoimmune disorders typically also have an inflammatory component, and that is where the corticosteroids step in to help. So for endocrine disorders, if your body's just not deficient in natural corticosteroids, we can give a supplement, exogenous corticosteroids, so that would be one indication for using these. The autoimmune disorders, again, we're trying to suppress the immune system so that it doesn't attack the patient's own body, in addition to suppressing the immune system and stopping like an organ rejection after somebody gets an organ transplant. It's also going to help reduce some of the inflammation. So if a patient has lupus, that's an autoimmune disease that has an inflammatory component. So it's going to help, one, control the immune system, and two, control the inflammation, improve that patient's outcomes. Other inflammatory disorders which are non-autoimmune in nature, the first one's bacterial meningitis. And this might seem kind of weird to you because I just said taking these medications increases your risk of infection. And if you have an infection, that seems kind of like a weird thing to do. The reason why it's used in bacterial meningitis is sometimes it's warranted to have that immunosuppression, even though there's an infection there, to help protect the spinal cord. Because with meningitis, as the meninges become inflamed, it puts pressure on the neurons and nerves, and if that pressure is not relieved fairly quickly, it causes a lot of pain, but it can also cause permanent damage. So that is why a corticosteroid might be used for bacterial meningitis. And then they're also going to be on some heavy-duty antibiotics to help control that too. I frequently give IV corticosteroids to relieve cerebral edema. It's not unusual. Somebody, say they're in a car accident and they hit their head and they have a head injury. With that head injury comes inflammation. And inflammation in the brain is a really bad thing because there's nowhere for those tissues to expand. So as the tissues become inflamed, it squishes on the brain, and that can cause further damage. So we'll give a corticosteroid to help suppress that inflammation. We do that quite frequently. We'll also do it prophylactically for patients who have had some sort of neurosurgery. So if they've had like burr holes placed into the skull, or if they've had a cap removed or anything of that nature, we'll give this prophylactically so that any inflammation which might be induced is suppressed. And then the next spot that's probably most commonly used for corticosteroids is asthma. And we're going to hit this really hard when we talk about asthmatic medications, but just know the anti-inflammatory component of corticosteroids is a popular indication for it to be used for asthmatic patients. A couple contraindications. Obviously, if you're allergic, please don't take it. That's not going to be helpful. But then there's a couple other conditions where if you take a corticosteroid and you happen to have it, it's going to exacerbate that disorder, or it's going to make that disorder worse. The big ones are going to be cataract formation and glaucoma, because corticosteroids can cause both of those. Patients who already have an existing cataract or existing glaucoma are not good candidates to receive a corticosteroid therapy if another therapy exists. Sometimes, like if they have a closed head injury and it comes down to exacerbating a cataract or saving them from head trauma, obviously we're going to go trying to prevent head trauma. A cataract can be removed later, so that's not quite as scary, so you kind of have to weigh pros and cons. But if it's something like with asthma and we can use a different anti-inflammatory medication, we may elect to go that route. Also, peptic ulcer disease, you'll see when we hit side effects, which is on the very next slide, that these drugs are notorious for causing gastric ulcers. So if the patient already has an existing ulcer, giving a corticosteroid is going to make that ulcer worse. In addition to it being very painful for the patient, it can also become deadly if that ulcer erodes the entire way through the gastric wall and causes a perforation. Then it results in sepsis, which is a body-wide disease infection, and they typically end up in an intensive care unit somewhere. And then diabetes. Corticosteroids cause blood sugars to increase, which is going to wreak havoc with your diabetic patients. Now, due to the immunosuppression effect of corticosteroids, because remember, it's shunting the immune system away, it's kind of shutting the immune system down, we need to use it cautiously in patients who have an active infection, and that can be bacterial, viral, or fungal infection. We also want to use it cautiously, like around children, because they tend to also have a compromised immune system. So just understand that sometimes these drugs will be avoided due to secondary comorbidic conditions that the patient may have. Now this is kind of a fun area because this is where you can really start exercising your nursing knowledge and starting to make a difference in patients' lives. Because I anticipate you've all gone into, even if you're not going into nursing, you're going into the medical field to make a difference in people's lives. And preventing adverse effects of medications is one of the biggest areas because there's so much we can do to help minimize or prevent these side effects that it's just so good to apply the knowledge you have to the general population to help promote health. So with that in mind, let's kind of run through the adverse effects. The first blank on your outline is short term. I could highlight it on my screen, but then you couldn't read it. So just fill in short term side effects, and we've got it divided from short term to long term. So the second blank on your outline is going to be long term. With that in mind, some of the short term, so even if the patient is only taking a corticosteroid for 10 days, say they had a acute attack of asthma and they're just on it for 10 days, they're still going to experience the short-term side effects. Those include edema, kind of just my own thinking to help prevent edema. You could encourage them to wear the TED hose, those really tight stockings that we pull on patients to help reduce the edema. Also sitting with their feet up and limiting salt intake will help reduce that. It's also going to cause a spike in blood pressure, so to help prevent that, we encourage people to maybe limit their salt intake. And then it might be a good idea just to monitor your blood pressure daily while you're on this if you already have hypertension. And you can teach a patient or advise them to pick up, if you go to like Walgreens, you can get a blood pressure monitor for like $10. And that might be something for them to consider. The edema and the hypertension both come from the fluid retention from the mineral corticoid part of the corticosteroids. Now the mood swings. This is something that we can't necessarily prevent, but we definitely want to let them know while you're on this, you may feel a little bit more emotional. You might feel like you're just a little bit more stressed. These drugs are notorious for causing mood swings all over the place. In addition to that, it can actually also cause a psychotic episode. Again, for this, we can't really do anything to prevent it, but you'll want to monitor the patient if they're in the hospital, and you will want to advise family members just to be on the lookout for changes in behavior. The insomnia, they may wish to take like a Benadryl to help combat that, so just let them know this drug may induce insomnia. Alternatives would be to take melatonin, Benadryl, something of that nature if it becomes an issue. The next one is going to be hyperglycemia from the altered glucose metabolism. So for this, we may advise people to reduce their carbohydrate intake, particularly their sugar or their sweet carbohydrates. Fiber is still, it's a carb, but it's still good to take while you're on a corticosteroid. But they may want to avoid stuff like ice cream, cake, candy, stuff of that nature. Also, if they're diabetic, just warn them, you may need to increase your dose of insulin. And not that you're going to be the one to tell them to do that, you just want to reassure that that's an anticipated result and that it will go back to normal once the drug is done. Just kind of reassuring them. May also encourage them to exercise and again, follow a SMART diet, diabetic diet. These drugs also increase your risk for bleeding. So patients just might notice they bruise easier. Just letting them know so if they do develop a bruise on their shin from bumping into a table, they don't get alarmed. And the last one is acne. So they may need to go on some acne cream medication or just so that they know that they're more prone to breaking out. Again, not deadly, not going to hurt them, but it does alter it could potentially alter how they feel about their body image, particularly teenagers. So just be sensitive and address it. Now on the flip side of the screen, we have our long-term side effects, and these are side effects which are going to occur if somebody is taking the medication over a longer period of time. So now we're talking about our patients who have like rheumatoid arthritis, and they take these for many, many years, or they've had an organ transplant, or something along those lines. They have lupus, they have something along those lines. The first one, there's heart failure, and this is caused by the retention of fluid. As you retain fluid, it increases your blood pressure, and as your blood pressure is increased, it causes the heart to be more stressed, which can then over time develop into heart failure. Once heart failure develops, it is irreversible. We can control it, but we can't reverse it. So for these patients, we really want to stress, if they're on long-term corticosteroids, limit salt intake, the importance of exercise, also to control their blood pressure. So this might be another category of patients that wish to purchase a blood monitor and just once a week or once a month check their blood pressure to make sure it's not getting too high. In children, we worry about growth suppression. There's nothing we can do to prevent that. So for this reason, if a child can be treated with a medication that's not a steroid, we will opt to go that way. But if they have to have a steroid, just to understand there is that risk of growth suppression. The next one is Cushing syndrome, and that's simply referring to an overdose of corticosteroids, and it results in weight redistribution. And where the weight goes, it relocates from like the arms and legs into the shoulder blades. So patients will get what we call a buffalo hump, and around the face, which the vocal term is moon face. Again, not very good for the self-esteem, but kind of something that's inevitable. We can do our best to educate patients that you may wish to lift weights, work your arms, work your legs a little bit more. Be very careful about what you eat, because any extra thing is going to go right to those two places. And once you have kind of fat around your shoulders, it's rather hard to lose. So again, prevention versus trying to treat it. Can cause menstrual irregularities, becomes an issue if somebody's attempting to get pregnant. Can cause HPA suppression. And then number 6, I really want you to highlight. These drugs are notorious for causing peptic ulcers. For that reason, we advise patients not to use other medications, which might also cause an ulcer. And the big one's going to be ibuprofen. Ibuprofen is another notorious ulcer-causing medication. So telling patients, if you have a headache, use Tylenol. Don't use ibuprofen if at all possible. Aspirin is another one that likes to cause ulcers, but sometimes the risk of the ulcer is worth it because they're taking aspirin to prevent a blood clot. So again, weighing pros and cons, but if you're taking it for a headache, no, take something else to help stop that pain and not cause yourself to get an ulcer. And of course, you'll teach them about signs and symptoms of ulcers. Once you learn about those, some of your early signs is pain, either before or after eating, depending on where the ulcer is. And then it can also cause you to have bloody stools if it gets bad enough, but you'll learn about that later on in the program. The next one, number 7 on your outline, is poor wound healing from prolonged hyperglycemia. So as the blood sugar stays raised, like we covered in the last lecture, it causes vessel damage. That vessel damage comes through as blindness, can cause kidney damage, can cause coronary artery disease, peripheral artery disease, and as blood is getting shunted away from the peripheral artery disease, it causes any break in the skin to take a lot longer to heal, because your blood supply is also bringing your immune system to that point. So if the blood's no longer flowing there, neither is the immune system. It's just not going to heal. For that reason, it's really important that patients are doing a good skin assessment. If they note they have a cut, watch it to make sure they don't get it infected, and that they're coming to the doctor at early signs of infection so that we can help treat that. The next one is the muscle weakness. Again, weight-bearing activity is key for this. And then osteoporosis. Again, weight-bearing activity, and then you may also suggest them to increase their calcium intake, vitamin D intake, and just be kind of aware that they are at that increased risk. Your last one there is weight gain. Again, this is kind of inevitable from the Cushing syndrome, but we can help minimize it, and it can be prevented. It's just very, very difficult. It requires a lot of work and dedication on the patient's part to watch what they eat and make sure they're sticking to an exercise regimen, because as soon as they overeat and don't exercise, they're going to feel like they blow up like a Macy's Day Parade balloon, which is just no fun for them. And again, everything else is going on with the mood swings and the acne and the insomnia and everything else, that then when their appearance starts to change, it can have a lot of psychological effects for patients too. So anything we can prevent is really, really good. Okay, moving on to interactions. There's a bajillion, but we're just going to go through a few of them. The first one's a potassium wasting diuretic. Now, right now, I don't anticipate you to be able to see a drug name and be like, oh yeah, that's a potassium wasting diuretic. But when we cover these, when we cover cardiac stuff, I'll expect you to recognize, oh yeah, corticosteroids are going to interact with that. So right now, just put it in your notes. Don't stress about learning what those are or what they do. Just kind of put it in your notes. And understand that just based on the name, you can probably understand that potassium wasting diuretics cause the body to get rid of potassium. So if you're taking a medication which causes potassium loss and then you also take a corticosteroid, it can result in some really low potassium levels, which can affect cardiac function. And that's all the more of the potassium wasting you need to be concerned about for right now. The next one, aspirin and NSAID, again, it increases the risk of ulcer formation. So no ibuprofen, no Aleve, no naproxen. If at all possible, avoid it. Immunosuppressant therapy, again, right now you're not going to look at a drug and be like, oh yeah, methotrexate, that's an immunosuppressant, but at the end of the class you'll be able to. So right now just tuck it kind of into the background of your knowledge. Corticosteroids themselves cause immunosuppression. They stop the immune response, so then if you add another drug on top of that that also suppresses the immune system, patients are going to be at a huge risk of infection. And then the anti-diabetic drugs we've talked a lot about this week. These increase the blood sugar, so they may just need a higher dose of what they're on to help control their blood sugar, and they need to be aware of their diet and making sure that they're being smart about what they eat. A few rules of corticosteroids in general. These tend to be easy to pick out of a lineup because they all kind of sound alike. They tend to have S-O-N-E in their name, or they might have S-O-L-O-N-E in their name, which isn't on your PowerPoint, but they all have that kind of Sone or Salone in their name, which makes them, again, easy to identify. For administration, there's many different routes. It can be given oral, IV, intramuscular, topical, inhalation, or intranasal. Remembering your pharmacokinetics, your IV are going to be your most potent and have the most side effects associated with them, while your topical and inhalation are going to have the fewest side effects. Also, if you're giving this IV, make sure you're pushing it very, very slow. And you'll want to check a drug book before you give this. I don't remember off the top of my head what the appropriate rate is, but typically for like 5 milligrams of methylprednisone, we'll push that over about 5 minutes. So just know that you're pushing these really slow. If you push an IV corticosteroid fast, your patient's going to start feeling really flushed. They're going to feel like they're going to pass out. They get dizzy, they get itchy, and it's just not comfortable for them. So again, just push it slow. Don't go too crazy there. And then the next thing is also important to remember, and that's got to do with the dosing. With this, you always want to start with the lowest dose possible and slowly increase. Likewise, when the dose is stopped, it can't just be stopped suddenly. It has to be tapered down. So say they were on 10 milligrams of prednisone for whatever reason, and then they go from 10 milligrams to 7.5 for a few days. And then they'll go from 7.5 to 5 milligrams, and then they'll step down to 2.5. So they'll be tapered over a period of at least 10 days probably, before they're totally stopped. And it doesn't take, the reason why you have to do this is because your body builds tolerance to it, and your adrenal glands quit secreting endogenous corticosteroids because you're getting it from an outside source, so then your hypothalamus isn't sending that signal to the adrenal glands, or to the pituitary gland rather, to secrete it. Because that signal's been shut off, if you stop these suddenly, causes the hypothalamus to go crazy and be like, wait a minute, now I went from having an adequate amount to not having anything, and it'll throw the adrenal glands into overdrive, and you'll cause a crisis event. You'll cause a circulatory collapse. So that's no good either. And that tolerance can build within 1 week's worth of use. So even if it's a short course of corticosteroids, we still slowly start them and slowly stop them. You never ever want to just stop real fast. So the first drug you need to know is one which acts more as a mineral corticoid rather than a glucocorticoid. And that is your fludrocortisone. So you can see the SONE there at the end of the name. Because it's got that mineral corticoid activity, it's going to work a lot with the fluid volume balance. It's going to cause a lot of fluid to be retained and a lot of sodium to be retained. It's indicated for insufficiency, so for adrenal corticoid insufficiency, also known as Addison's disease. And the adverse effects that are particular to this medication, again, they come from retaining fluid. So the heart failure, retained fluid increases the blood pressure, which is number 2 there, and the hypertension is what's going to cause the heart failure. Also, as you retain fluid, it will get leaked out of the vessels, and then you'll have some edema. And what happens, or how it causes the seizures, is you retain sodium. If the sodium level gets too high or too low, it can induce a seizure. So if it keeps building up in the system, that can induce a seizure, making it a side effect particular to this medication. Your interactions, again, there's a bajillion of them, but we're just going to talk about a couple. People who are taking anabolic steroids, and anabolic steroids are the ones which athletes abuse they're the performance enhancing drugs. If they take an anabolic steroid at the same time, it's just going to increase the edema, which is going to increase the stress on the heart, increase the blood pressure. Now there's a couple different categories of drugs which increase the drug clearance, which is going to increase the drug decrease the drug potency, as it's getting excreted quicker. Those include your barbiturates, which are not used frequently anymore because they're not a very safe drug. And then the estrogens, which we're going to cover in the next chapter. And then there's certain drugs which will cause the potassium to fall low. The first one's amphotericin, which is sometimes also called amphotericin, and that's just an antifungal medication that has a ton of side effects associated with it. And then the thiazide and loop diuretics are the potassium wasting diuretics that we just talked a little bit about earlier. Again, you don't have to worry about knowing those drugs. Just tuck that knowledge into the back of your mind, because then when we cover them, I'm going to say, remember when we talked about corticosteroids and I said they interacted, and then we're going to talk about why they interact. So just kind of tuck that knowledge into the background of your brain there. The next drug we're going to talk about is prednisone. And this is probably the most widely prescribed corticosteroid. It's a pretty good one. It comes in many different routes. It can be oral, IV, or IM, and I think there's also a topical one too. This is what we would call an intermediate acting corticosteroid. It's got a relatively long half-life of 18 to 36 hours. Not that you have to write this down, but your short-acting corticosteroids, I think, have a half-life of around 6 hours. And the long-acting corticosteroids have a half-life of around 72 hours. So these fall kind of right in the center. Having that extended half-life allows these medications to be given every other day. By giving them every other day, it can help decrease the incidence of side effects. So that's why we like using prednisone, is because it can be an every other day thing. Some of the common indications, and typically these are going to be delivered via a tablet, via the oral route. The first one's going to be immunosuppression for your autoimmune diseases. And again, your autoimmune diseases are going to be like lupus, rheumatoid arthritis is another one, celiac disease, ulcerative colitis, all that stuff. It can also be used short-term for asthma control. And we sometimes also use it for athletes who develop tendinitis or bursitis. Can help relieve that pain. Some of your side effects, now absolutely everything that we talked about, I think we spent 10 minutes talking about side effects. Those all apply to prednisone. It does each and every one of them. If it's just a 10-day course of prednisone, be thinking short-term side effects. If it's a long term, if they've got rheumatoid arthritis and they're taking it for many years, start thinking long term side effects. Again, never ever stop it. Always taper it. Always slowly start, slowly stop. Educate your patients. Don't miss your dose. Don't skip your dose. Don't stop taking your dose. Patients sometimes get this idea, especially ones who are using it for asthma, get this idea in their head that, oh, I feel better after day 7. I'm just going to stop and save it for later, and then they end up doing a lot of harm to their body. So just educate the patients on that as well. The next one is methylprednisone. Routes for this, intravenous and intramuscular, and it also comes in an oral or a tablet form as well. This is a very popular intravenous one. Again, make sure you push it slow, but I give a lot of this for our patients who have head injuries. This is a very common medication on the floor for patients who have that cerebral edema. When you're giving it IV, remember, you're going to have the most side effects associated with it. And you always give it very slowly. And then it can also be given intramuscular. And intramuscular methylprednisone is going to be for somebody, again, who has like rheumatoid arthritis, or they've had an organ transplant and they're trying to suppress the immune system. For that reason, it typically comes in what we call a depot formulation. And anytime you see depot associated with the drug, so methylprednisone depot, just understand that that's a long-acting intramuscular injection. So it's normally like a once a month they come in, they get their depot injection, and then they go on about their way. Again, indications can be edema, immunosuppression. Those are typically when we see this one used. We have one more drug to cover, and this is actually an anti-adrenal medication. So the rest of the medications we've talked about have been corticosteroids, so they're pro-adrenal drugs, if you want to think about that. They stimulate corticosteroids. This one's actually going to stop the production of corticosteroids. The only drug you need to know from here is the aminoglutathione. And what this does is it acts as an adrenal steroid inhibitor, which is going to obstruct the normal actions of the adrenal cortex. In doing so, it inhibits the conversion of cholesterol into the adrenal corticosteroid. So it's going to stop glucocorticoid and mineralocorticoid production. We typically use it to treat Cushing's syndrome, although it can also be used as palliative treatment for certain cancers, particularly cancers of the pituitary gland, renal cancers, and adrenal cancers. Some of the adverse effects include nausea and anorexia. It's really hard on the liver. Cause some low blood pressure, lethargy, and weakness. Some of these are the exact opposite of what your corticosteroids would cause, like the hypotension. Your corticosteroids cause hypertension, so this one's going to cause hypotension. Your corticosteroids cause insomnia, so this is going to cause lethargy, kind of thing, if you want to think of it in that aspect. There's some which are the same, like weakness. They both cause weakness, just working in a little bit different route. Now the last page of notes, I'm not really going to go through in this PowerPoint because I think you probably heard enough of my voice, or probably more of my voice than you want to hear in one setting. But this was just a quick care plan that I kind of threw together to help you develop how to think about these drugs and how to critically think about them. And I pulled it from your textbook too, so you can certainly look there for more ideas. But just understand it's not all-inclusive, so don't feel like just because it's not on this outline, it's not applicable. As you sit here and look at it, you're going to come up with your own ideas too, and that's okay. That's encouraged. This is just to kind of get the ball rolling a little bit. So with the nursing process, you always start with an assessment. You need to see what your baselines are before you start anything. So before corticosteroids are started, you always want to get your baseline nutritional, hydration, and immune statuses. Because these medications are going to cause weight gain, they're going to cause fluid overload, and they're going to decrease the immune status, we want to know if there's any problems there already. You're going to be more concerned about patients who are already overweight taking these medications because they've already got kind of like one strike or, a strike against them essentially when it comes to weight gain. Or patients who are already immunocompromised. Understand they're really going to have to be careful about avoiding sick people washing their hands, because if they're already immunosuppressed and then we give them a corticosteroid, you're going to wipe their immune system out. And it might be necessary for some reason, but just be thinking, well, even if they have to do this, how can I help minimize that effect? Again, we want baseline weight, I's and O's, vital signs, particularly the blood pressure. Again, if they're already hypertensive and then we give this drug to them, it's going to make their blood pressure worse. So want to identify those problems before you start. And that's essentially what this all is trying to identify any existing problems before you start the therapy. Lab values, you'll be looking at sodium, potassium, and glucose, and then you're also going to want a complete medication list, so everything they're taking at home. And keep in mind, this is going to include your over-the-counter medications such as ibuprofen, because if they take ibuprofen a couple times a week for headache, back pain, whatever it might be, then they start a corticosteroid, you're going to be really concerned about the development of ulcers. So just kind of keep that in mind. You're also looking at their home, their non-over-the-counter medications too. And obviously if they're on insulin, if they're on potassium-wasting diuretics, that stuff we talked about as well, you want to take note because they might need to suddenly be on a potassium replacement or increase their intake of potassium or something along that line. And then you hit the planning and implementation. This is where you're going to actually have a lot of fun at because you've identified what your problems are, and now your task is, well, how am I going to prevent this? If you have any aspirations of going on to become an advanced nurse practitioner, so a family nurse practitioner or a nurse anesthetist or anything of that nature, this is essentially what your whole life is going to be. You're going to find a problem and then you're going to figure out how to prevent it. So I give you guys kind of a few examples on your outline you can read at, but you come up with your goal. So for example, say your goal is preventing osteoporosis. You're going to protect your patient from a side effect. They've got their organ transplant. I'm concerned about their bones because they're a female and they're postmenopausal and whatever it might be, so I want to prevent osteoporosis. What am I going to do? I'm going to suggest maybe they do weight-bearing exercise. And this is where you start pulling information from other classes as well and pushing it forward. Oh, well, I know how to prevent osteoporosis. I'll have them do X, Y, and Z. And sometimes you have to look into it a little bit. Like, I know gastric ulcers can be caused, but I don't know how to protect the patient from that. So you might end up doing, when you identify a problem, you might think about it a while and have to look it up. You can certainly use your online resources. You can bounce ideas off me if you need ideas, off each other, but that's kind of how you grow in this. So that's just my little critical thinking building exercise or activity for you for this lesson. And then of course, once you've identified your goals and your interventions, you must evaluate. If you don't evaluate, you kind of fall off on the follow through, if that makes sense. So make a goal, decide how you're going to accomplish that goal, and then, well, did it work? And sometimes your goals won't work, and that's okay. You just have to figure out, well, what else can we do? So for hypertension, they still had an increase in blood pressure. They've stopped eating salt. They've been exercising. Maybe now it's time to call the doctor and see if they need a different antihypertensive medication, and that's okay because you're still following through and working on the problem. And that will be the end of this lecture.